I'm ready.
3, 2.
Welcome to Season 3 of Boston Congress of Public Health's 4-part miniseries, The Great Health Debates. Boston Congress of Public Health is a 501c3 nonprofit organization whose mission and vision is to democratize public health through the lens of social justice and to transcend the traditional boundaries of academia and medicine. BCPH does this by supporting leaders, researchers, and advocates who are committed to social justice, health equity, and evidence-based public health thought. As the country becomes exponentially diverse and interconnected, how do we continue to effectively reduce disparities, and what does this look like? I'm your host, Fatu Barry, a current MPH candidate at NYU and fellow at Boston Congress of Public Health. I'm particularly passionate about global health, health equity, and health disparities. With this season being the promise and peril of cultural competence in healthcare, we will be delving into topics surrounding cultural competency, intersectionality, and responsiveness. This series will highlight the perspectives of health providers, professionals, advocates, professors, researchers, and patients and their encounters and experiences regarding health disparities, literacy, and equity. Cultural responsiveness, cultural humility, and cultural competency are terms we've heard thrown around constantly, almost interchangeably for some. These terms surround the need to reduce existing health disparities and ensure quality care for minority groups. But what exactly are the similarities and differences to these terms? And are they interconnected? What steps are needed to achieve health equity for all races, genders, sexual orientations, and body types in the US? Allow me to introduce our panelists for episode 2. We have April Aives. April Aives is dedicated to anti-racist public health practice. She currently serves as the Chief Equity and Organizational Cultural Office for Planned Parenthood, where she leads their strategy for operationalizing the undoing of white supremacy culture, centering communities most impacted by systematic oppression, and embedding equity at every level of the organization. Next, we have Jennifer Petty. Jennifer Petty is a legal epidemiologist, public health strategist, and health equity champion. Jennifer Petty's 14-plus-year career has led her to become a thoughtful leader and changemaker. She leads the Health Equilibrium Group, serves as executive director for the Maternal Health Conversations Collaborative, and serves on both the Emory University Board of Visitors and March of Dimes Georgia Chapter's executive leadership team. Next, we have Mr. Antonio Williams. Mr. Williams has been a public mental health counselor by degree and training for 15 years. Mr. Williams is also a community-based participatory and interventionist researcher and has worked in several community-based organizations, state governments, for-profits, and non-for-profit management institutions. And lastly, we have Ms. Taylor Rich. Taylor Rich is the Director of STEM and Leadership at Girls Incorporation of Worcester. She is also a first-year doctorate student in public health and the Graduate Research Assistant for School of Education, Health, and Human Science at Bay Path University. Hi, panelists. Thank you for joining us. I'm very honored and excited to have this discussion with such an esteemed group. Let's dive right into question 1. Jennifer, I'd love to start off with you. How do you define the terms cultural competency, cultural responsiveness, and cultural humility? And is there a better term for the other?
Yes, good morning, and thank you for having me. I think that cultural competency in healthcare from a textbook standpoint describes the ability for systems to provide care to patients with diverse values, belief systems, behaviors, tailoring healthcare delivery to meet the needs of patients' social, cultural, and linguistic unique needs. I think that this is an interesting time to have this conversation, given that, in certain areas of the country, just the word equity, right, or cultural or diversity is under attack. And this has implications when you look at cultural competency in healthcare. So for instance, we need diversity in our hospitals, amongst our healthcare professionals. And in order for us to get there, we need diversity reflected in our medical schools, in our nursing programs, in our public health programs, and so on. And so when you have policies in place that attack, those words, those terms, terminology does matter. And terminology does have serious implications for healthcare.
That's interesting. Would any other panelists like to give their perspective on this question?
So I think when we look at these terms, competency, responsiveness, and humility, there is a cross trend, right, that happens. However, I think from a standpoint of a person who has worked on the provider side and has been a patient, it does not always translate to every single organization and its entirety. For instance, we try to do things to make ourselves responsive, also while having humility. I've seen instances where an institution is dealing with Black gay men and they go hire a Black gay man off the street that they think that would be appropriate, but it's not always necessarily the appropriate person. So I think for institutions to also understand, you have to get to the nitty-gritty aspect of this and also find the appropriate way to make this work for every individual. Because from one Black gay man to another Black gay man, there may be levels of hierarchy that they don't both encounter, but you've selected someone that's supposed to be your competent person and to treat the patients and teach the staff how to do it. And that person may not be the appropriate person.
All right. So these terms, cultural competency, cultural responsiveness, and cultural humility, they're mainly used in ways that we can reduce health disparities. I kind of want to talk about the mechanisms that have been used to reduce these health disparities. April, I'd like to come to you on this one.
Sure. So for me, I will actually say I am not a fan of using the term cultural competency. I don't think anyone could, ever truly be competent in all other cultures. And I also feel like cultural competency really centers whiteness. I really like the term using cultural humility because it actually focuses on the individual and focuses on the need to really reflect and think about our own biases and the way that we are, perpetuating harm. And again, like in the term, we have to be humble and realize that we don't know everything. And that can be difficult for, folks. So I really enjoy cultural humility for that standpoint. And so I will say I do believe in the healthcare industry that there is still a lot of framing and training and a lot of programs that are dedicated to cultural competency. And I will say that there's more research out there too around just the harms of using that framework. And not just harms, but how it isn't necessarily really making the shift, making the changes that we so urgently need in healthcare in this country, right? Rooted in, racism and white supremacy. So for me, I think it would be more promising to really see more interventions that are focused around that cultural humility and asking people to do their own work, do that internal self-reflection that's needed. Because without that, it's really difficult to learn and grow because we all have our own work to do.
Any reactions or similar thoughts from any other panelists? Okay, so I kind of want to dive a little deeper into this question. Taylor, I'd like to come to you. Can you describe any mechanisms that you are aware of that have been utilized to reduce health disparities in the US and maybe touch on their effectiveness or their non-effectiveness?
I think there has been a few advantageous moves to reduce health disparities, but we certainly have a long way to go. The current state that we have with reproductive health, Black maternal health rates, and how we care for immigrant, non-English speaking, and refugee communities vastly differs than people who identify as white and speak English. In my own personal community, there was a vaccine equity initiative that was funded by the Department of Public Health, which we saw a lot of great progress in. They were able to go into low-income neighborhoods and public housing and offer incentives to get vaccinated. However, I think that there is, again, a large need for historically marginalized populations such as Indigenous communities, in which the trauma between the colonization and the communities runs so deep that we shouldn't expect them to sign up for anything that has been offered by people that there is a lack of trust from, rightly so. And I would like to just highlight, there's a lot of terms like evidence-based treatments, but who is this evidence being conducted on? We need to look at the rate of health disparities as a framework of how can we treat people better in the way that they want to be treated, not just giving everyone a one-note treatment plan because it's just not effective in that way. We need to be sensitive to their religious backgrounds, to their cultural beliefs, and only then I feel then we can make some headway in terms of health equity.
That's very interesting, Taylor. And which brings me to my next question, perfect segue. What does care look like today in the States for Black Americans, for Latinx Americans, immigrants, refugees, the disabled, and the LGBTQ community?
I'll take that one. You know, what does it really look like is a conversation I think that we need to just have gut level, honest conversations about, right? Because as a person that's sitting at the table that covers a couple of these different areas in which we're talking about Black America, Latinx America, immigrants and refugees, disabilities, morbidly obese, LGBTQ plus, I don't think that we have the conversation at its core. And when we get to the core of what this looks like, maybe people will have a little more sympathy and empathy for the person that's sitting on the other side of the table. I grew up in Mississippi, so that's deep South, as most people call it. But there are pockets that I've learned, not just in Mississippi, but just in other Southern states, where people drive 2 hours just to see a primary care doctor. That's, to me, is a little insane. And then we have people that get on their high horses that have insurance and they can just call up the doctor and be like, oh, I need XYZ. And they never step foot into the clinic to be seen by the doctor. And the doctor writes the script and send it to the pharmacy and they just pay whatever they need to pay. Or they just pop up to a doctor and give $500 and go through. But when we really sit and say what this looked like, it is very deplorable for some people. Particularly if we go and we look at socioeconomic statuses for persons living with HIV, right? We look at some of the individuals are traveling very far just to see an infectious disease doctor that's newly diagnosed. We haven't even talked about the mental health aspect and things that come along with that. And I think once we start to take a look at these things, then we can actually increase what we call healthcare. Because right now, I think we're very stagnant, and considering that the laws that are being passed down from majority Republican states, where we can't use the word gay, we can't treat persons with trans experience, or for that instance, people that are non-binary, that creates a barrier. So that person does not feel comfortable with trying to do what he, she, or they want to do because of the barriers. And then that increases our suicide rates.
Thank you for your input, Antonio. Jennifer, I'd like to ask you, if you were to ask April, in terms of her background, within public health, regardless of terms, how do we make sure that patients feel supported and heard, and her perspective on that?
I'm sorry, could you repeat the question, please?
Yes. So if you were to ask April, based on her public health perspective, just on the patient-provider relationship and how terms, I'm sorry, I'll just go to the next question. Regardless of terms, how do we make sure patients feel supported and heard? And if you can give your perspective on that and maybe ask a panelist their thoughts.
Sure. That's a great question. And I think that it is one that is paramount and still just a great challenge to many providers. I have personally experienced this and know, of course, too many people who have. You know, I am a self-proclaimed maternal health champion, in large part due to my experiences, but also due to just the maternal mortality crisis at large. And so a culturally competent healthcare system, from my perspective, is not one that harbors a maternal mortality crisis, where Black birthing people, for instance, are 3 to 4 times more likely to die due to preventable pregnancy-related challenges. So a culturally competent system, for instance, wouldn't have taken Kira Johnson's hemorrhaging for granted, right? When she and her husband complained to doctors and nurses several times, a culturally competent system would not have, ignored Dr. Shalon Irving's conditions, which caused her to die. She was a PhD leader at the Centers for Disease Control and Prevention in Atlanta. A culturally competent system would not have failed a renowned tennis star like Serena Williams. And so I think that when we look at the maternal mortality landscape, I would be very interested in maybe hearing April's thoughts given her role with Planned Parenthood.
Yeah, thank you, Jennifer. For me and Planned Parenthood, we offer a wide array of services, both related to family planning, STI protection, abortion services, HIV/AIDS services. So really a well-rounded approach in addition to advocacy and education. And I will say, something that I am really working on here at the Planned Parenthood in Arizona, where I'm located, and Arizona being a state where we do have, bills that could potentially be passed around limiting transgender, non-binary folks' access to gender-affirming care and services of that nature, and where we do see, high maternal mortality rates as well for Black populations. And I will say, with Planned Parenthood, it's tricky because for us, we really have to do even more work of just acknowledging the historical and current harms of the organization. Planned Parenthood as a whole was really rooted and created in white feminism. And the founder, Margaret Sanger, she was a well-known person who aligned with folks that were in the KKK, in the eugenicist movement. So, that being the founding of Planned Parenthood in itself, says a lot about the system itself and the harms and the way that we have perpetuated inequities, right? And not necessarily prioritizing the Black and brown communities, indigenous communities that we really need to. So that's something that I know earlier on Taylor talked about trust as well. Like, that's a big thing for us, especially when we're thinking about maternal health in general, is really building that trust, because we may not have that trust in Black communities. We may not have that trust in indigenous communities, right? Especially when we think about just all of the harms overall of medical racism, but then, taking into context just all of the harms that Planned Parenthood has done and being realistic about that. There's a lot of that acknowledgement and really reconciliation that's needed. And that takes time. And I'd say right now, we are at the point where we are, openly acknowledging the history here, not only just of Planned Parenthood nationally, but Planned Parenthood in Arizona too, a place where Margaret Sanger herself, the founder of Planned Parenthood, founded one of our health centers here in Tucson. So, there's a lot there, and there's a lot to unpack. And it's, having conversations with community members. It's making sure that our staff are even aware of that history, and making sure that we're doing everything we can to again, acknowledge, thinking cultural humility, humbling ourselves, remembering that we don't know everything, and communities, more than we do about what their needs are and what they need and want. Um, and so I would say, there's a lot of work to be done. And it's really just making sure that we're prioritizing communities that are most impacted, and making sure that we're building that trust along the way, because that's so important.
Yeah,
So I
and
think,
Antonio, I'm sorry, go
I'm
ahead.
sorry. No, I just want to add to what April is saying, because I think oftentimes we forget that we create these barriers, right? And a person struggles with themselves to get a lot of things done. And so that's already one barrier. Then we have the interpersonal barrier, then the organizational barrier, which actually, when we get to the doctor's office, that's an organizational construct or an institutional barrier that most people don't know how to navigate. And someone, myself, who recently went through some medical situations and having to make determinations and figuring things out, it was a struggle for me. So if it was a struggle for me, what do we look at this young African American male who is couch surfing and has no one to turn to, and trying to figure out how to provide competent care for himself or herself, if that's the case. So breaking down these barriers, I mean, from an interpersonal, organizational, community, instructional level, can be a great way for us to start to achieve health equity. And when providers start to think about these things, then I think they will become more accessible to people. And it's not oh, I got to go see the doctor type deal. People will be yearning to go. People will be wanting to go because they know they're going to have a great experience and not worry about whomever sitting at the front desk criticizing them of how he or she may look.
Right. And speaking of barriers, Taylor, you mentioned prioritizing transparency and trust within the patient-provider relationship. Can you talk a little bit more about where healthcare providers sit on this cultural humility conundrum? What is their role? Are they leaders? Are they followers? Are they both?
It's difficult. I think to April's point that competency, that word just doesn't support what needs to be done in order to care for individuals, particularly if they don't look like us or have the same language, or if they have a different history. The term intersectionality comes to my mind in that I think providers follow both a leader and a follower. I think there needs to be more representation in the medical field, so that way more patients do identify with their provider, but that also leads to the inequities of access to higher education, especially with first generation populations. So to that effect, I believe that if you have a provider that looks like you or speaks the same language, they're able to lead you in a way that's different than one that doesn't. We often see a lot of family members being subjected to translating some pretty traumatic information to their family. And I personally don't think that that is something that anyone should have to go through. And so in terms of whether you're a leader or a follower, I think if we are providers that do not identify with our patients, whether it be through race, gender expression, sexual preference, religious or spiritual beliefs, I think we need patients to lead us in the way that they want to be led and they want to be healed. We as providers sort of have an arrogance that we think that we can just create a treatment plan, people are going to follow it, everybody's going to be healthy, it's going to be great. But the truth is that many communities have healed themselves, particularly Indigenous populations, have healing, roles within their communities that have been effective for years. And so in those ways, we need to allow patients to have the true patient-centered care experience and be led in the ways that they see as a respectable form of healing.
Yeah, and speaking of interventions, Antonio, with your research background, I'd love to hear if you've completed any cultural competent training geared towards any race or identity, or have heard of any trainings and know of their effectiveness.
So to answer your question, yes, yes, and yes. Being a person who's worked in a national nonprofit, we created curricula that was used around health departments to discuss various topics around the competency, the responsiveness, and the humility piece of it. And it found itself to be great. However, until a person is ready to accept that they have a set of biases, right? Knowing what their biases are, they don't get a chance to get into that specification of being competent or responsive or having humility. Because oftentimes we don't think about things that affect a person and their decisions and judgments. I mean, we have studies at Harvard where implicit bias, and I guarantee you half of providers in the world have not gone through that to understand I have a cognitive or emotional or behavioral bias. And when we look at the behavioral aspect of it, I mean, it could be pretty daunting for people to think about how something makes them feel, and that feeling turns into a logic and it informs decisions that they make. And previous actions and false conclusions go into play.
What about other panelists? Have you guys completed any competent trainings or know of any?
Yeah, thank you, Antonio. I think you brought up a lot of great points, and I will say, yes, I think all of us have gone through trainings. I think that is the approach that we, as a society, has seen as the right way. I will say I am someone who actually would prefer less focus on training and more focus on that individual work. Because right now, a lot of trainings, especially even, cultural competency trainings, are very transactional. It's, you watch this course when you're, hired, or you, you hear from someone for an hour, 2 hours. Hell, if you're lucky, you can be in a nice, intensive 2-3 day one. Those are, I would say, most impactful. But then oftentimes it's that, and then you are left to, unpack, navigate things on your own, and it ends there. So I would say trainings, I don't think are really providing us all we need in order to do the work that we need to do in health equity, in healthcare. I will say, as I mentioned before, Planned Parenthood being a place that has been highly driven by white feminism, we're dealing with a lot of white supremacy culture in our organizations. A lot of these trainings, they don't touch on the ways that white supremacy culture shows up in organizations. For me, I'm thinking about saviorism, right? We have a lot of folks that want to provide, abortion services to every person in Arizona, and will work, and do that, feel like they have to save everyone. And in return, they're harming our staff, right? They're overworking our staff. Then our staff have to deal with burnout, mental, physical, well-being impacted. So then we're thinking about that. And that's something that, we see often in the healthcare industry, is this saviorism mindset. We think about paternalism, and, as Taylor mentioned as well, like, folks coming in, providers coming in, and assuming, that they know what's best, right? Like, here, follow this plan. Like, I know, I went to school. Like, trust me, this is, what is right for you. And that's also very harmful as well. Thinking about that urgency, everything needs to be done yesterday. Defensiveness, just something that Antonio, I feel like was, edging on as well, thinking about trainings and how, you got to sit in that discomfort and be comfortable with that being comfortable with being uncomfortable, right? And that's something that oftentimes can be difficult to do in just a small, less intensive, less transformational, training, where folks have more opportunities to get defensive and not really sit in those feelings and absorb all of those feels that they're feeling and really think about why that is, right? There's a huge mental health component to this, and us really having to do that self-reflection and that self-work, and being able to have someone that we can have those conversations with regularly. And so for me, it looks like it's consistent work. It looks like, having someone who is knowledgeable in this as a coach, right? Investing in that in organizations, investing in making sure that there is someone at organizations that can consistently, have that healthy level of accountability for folks too. To be able to, continually to say out loud, hey, I'm seeing a lot of saviorism. Hey, our healthcare staff, they're saying they're really burnt out. Maybe we are doing too much with too little people, right? That's very much something that we see in the nonprofit industry with always, trying to do too much, but never hiring enough people to do it. So there's a lot there. I know I just said plenty around trainings, but really I will say, yes, we've all taken trainings. No, not all of them have been helpful. I would say of all of the trainings I have taken, maybe like one or two are ones that really still stick with me and have made an impact. And I will say those have been the ones that are actually more intensive and have been 3+ days where you are in it. Our trainings and stuff like that, they aren't going to make the difference that we really want to see.
May I just add something to what April just said, and it goes along to the lines of staff and trainings. And I'm gonna hit a couple of points, and I'm gonna leave it alone. I feel, this is Antonio Tawan Williams speaking, that it's not the person's responsibility who is the marginalized community to teach learned people how to treat them, if you will. It's not that person's responsibility to come in and make sure that every DEI project that this person is on, so that everyone else that don't understand gets it. I implore every company to even starting with this leadership, starting with the board of directors and working its way down, to do the privilege walk. And Walmart has a commercial out right now where they are having these people walk a line. It's like, if you started out in this low level position and became a manager, step forward, and increasingly things like this to show how, I guess, inclusive they are with their hiring processes. Maybe, I don't know, didn't create the campaign, but I think that once we, as companies and individuals, not just look at what this looks like from their lens, but sit in our own stuff and stop stereotyping, stop benevolent bigotry, hostile bigotry, and look at the identities of the people, because 9 times out of 10, you don't really know what it has taken a person to get to the door. And that one little thing that you say that offends that person could actually be between them taking a gun and shooting themselves or them actually seeking treatment. Because all of this leads into other disorders and conditions. And being a mental health clinician, we stigmatize mental health so much to the aspect being people really don't get a chance to come in. And considering COVID and what COVID has brought on, it has really put America, if you will, in a situation where everyone are going through different bouts and different mental illness that they don't know how to handle, and we don't have enough therapists in the world to be able to provide care. So until we start talking about these things and trying to figure out how to make this work, then we can get to a better line of health equity.
Thank you, Antonio. And I know we've been having a lively discussion about cultural humility, cultural responsiveness from a provider standpoint. But I think it's really important before we end this discussion to shift gears and talk about the patient standpoint. We've heard the phrase, we're all patients in waiting. Jennifer, from a patient standpoint, can you describe an experience where you felt you needed to minimize or maximize certain aspects of your identity during an interaction with a provider?
Yes, I'm very excited to speak from a patient standpoint. I am a JD and PH. I work legal epidemiology. In particular, I focus on, policies and legislation and their impact on public health outcomes. And so as someone who is very much involved in this work, I also have a strong familiarity with statistics pertaining to health outcomes, right? And so when I was pregnant during the height of the pandemic, in 2020 through 2021, I was very much aware, you could say fortunately or unfortunately, I was very much aware of the risk associated with my pregnancy as a Black woman in this country. We know that, Black birthing people are experiencing preventable deaths 3 to 4 times compared to white counterparts. This is actually more so the case in states like where I live in Georgia, where it's significantly higher than 3 to 4 times. So Georgia actually, unfortunately, is the number 2 state in the country when it comes to preventable maternal deaths. So going into my doctor's visits, knowing these statistics, right, and perhaps having a little more familiarity with them than the average patient, gave me a little more anxiety around the whole process. I saw instances where my questions were brushed aside. And so I had to kind of overstate my professional background in order to gain the respect and get my questions to be taken seriously and receive answers. And that is sad because a patient should not have to tout their professional background to be taken seriously. You should not have to have a professional background, quite frankly, to be taken seriously. If a patient asks a question, that question should be taken seriously and should be addressed as best possible. After having my daughter, I experienced symptoms that were very much red flags. Textbook red flags. I called in several times. My daughter was at the NICU, so I saw several of these providers where I, asked, should my ankles look like this? For instance, should my temperature be this? And should my blood pressure be this? And, those symptoms were blown off. On a Friday night, approximately a week after having my daughter, I called the provider and shared with her that I had some very critical vital signs, my blood pressure, my temperature, just the way things were looking. And I was told, take a nap and call my office on Monday morning to schedule an appointment. This is on Friday. Thankfully, I have a cousin, a family member who is an OBGYN, actually in the state of Arizona. And I reached out to this cousin. And when I shared what my vitals were with her, she immediately told me to get into the car with my husband and to go directly to the emergency room And she got on the phone with those emergency room providers and told them that I needed to be treated ASAP and I was not to become another statistic in the state of Georgia. I say this to say, had it not been for that intervention, I do not know that I would be here to have celebrated my daughter's second birthday yesterday. This should not be the case. I think that, I wanted to circle back. We talked about from the provider standpoint, what role they can play or maybe even should play. And personally, I think that we need more providers to, of course, take part in what I call substantive implicit bias trainings. I had a conversation with Rose Horton last year. She is on the White House Maternal Mortality Task Force. She also serves Emory University in Atlanta. And she is a great resource who provides these in-person, really substantive implicit bias trainings for not only maternal health, but from a broad standpoint as well. And so I think that we need to do a better job of sifting through, those substantive programs versus those that, like someone mentioned earlier, that tend to be more passive. But I think there's room also for providers to, help inform legislation with initiatives that actually advance health equity, to reach out to their, politicians in their local areas and ask them to vote for, legislation currently pending that, has the potential to address these measures. I think that there's room for providers to call their medical schools, call their nursing schools, and ask them to, increase, the diversity amongst the applicant pool and accept, more diverse applicants. There's rules or room for them to address medical mistrust that was mentioned earlier and to really call it out, call them by name, call out the Tuskegee experiment, call out the experiments done on, female slaves in this country. And so I think that there is so much work that needs to be done, not only because of my experience as a patient, but just when you look at, health equity and statistics as a whole, there's a lot that needs to be done and can be done.
Thank you, Jennifer, for that powerful story. I'd like to shift over to Taylor because I know that she has also had a patient experience.
I want to thank Jennifer for sharing that story. For me, I'm an individual that lives with complex PTSD. I'm also a person in recovery, and I live with a chronic autoimmune disorder. I think that when we look at social determinants of health, we think of housing, we think of nutrition, and albeit those are all very, very valid determinants to the health that someone is. But I think we forget that trauma is a significant subdomain to that social determinant. I'm particularly a real big fan of the work of Dr. Nadine Burke-Harris in adverse childhood experiences. And she states that, if we were to go around with a flyer that said that there's this illness that takes 20 years off of people's lives, everyone would listen. But the second that we say it's from childhood trauma, things get a little sticky because it's a hard conversation to have. I found myself depressed, losing my hair, and having a myriad of other symptoms where I couldn't figure out what was wrong with me. I showed up to a doctor's office. I explained to them that, I had a feeling that I had this illness that runs in my family from many, many years. My grandmother, my mother, my cousin, my uncle. And still I wasn't being evaluated for that. And finally, after fighting tooth and nail, blood work showed that I did have this illness. And it saddens me because my identity has two privileges. I'm white and I speak English. So for me to have to advocate for myself when I already have a genetic disposition is really speaks to the inequities that we currently face in our system. I think that there are silos that providers are put in when it comes to mental health. Providers are Well, do you have a therapist? No. Okay, we'll get on this waiting list and they can deal with you that way. And again, it comes back to whole body wellness. There's about an 80% linkage between individuals that have complex PTSD and people that have autoimmune hormonal disorders such as myself. So we really need to look at what trauma causes in our body, and that's relative across the board, whether it's through poverty, whether it's through racism, whether it's through abuse, neglect, all of these factors that cause trauma. And I think especially coming out of a pandemic where we saw domestic violence rates skyrocket through the roof, we really need to have conversations with younger generations as to how the experienced trauma can show up as chronic illnesses that are long-term and need management.
Thank you for sharing that with us, Taylor. And that concludes our questions and discussion that we have for our panelists. And before I go, I just want to give you guys some key takeaways for those of you in the audience who have been watching from this episode. One, transparency and having those hard conversations. One of our panelists mentioned being comfortable with being uncomfortable. Two, focusing on the individual. 3, internal self-reflection. And 4, initiative in identifying personal biases from both the provider standpoint and for those who are in non-marginalized groups, taking the initiative to educate yourself. And lastly, I'd like to thank our panelists. Thank you so much for this enriched discussion. I really enjoyed it. And thank you to our audience for tuning in. Stay tuned for episode 4, where we discuss implementation efforts and intervention efforts regarding cultural humility and responsiveness. Thank you. Bye.